Dr. Karim Komusani. Dr. Karim, he graduated from King Abdulaziz University in Jeddah. Then he done his training in internal medicine, GI, and transplant hepatology at Western University in London, Ontario, in Canada. Then he was appointed as an assistant professor of medicine. He currently took the position of program director of gastroenterology and transplant hepatology at Western University in London, Ontario, Canada. Has several publications and has an interest mostly in HCC. He will talk to us today about the nutritional evaluation and management in cirrhosis. Karim.
Thank you, Dr. Qutb, for the nice introduction. And thank you for the organizing committee for inviting me to be one of the presenters. It's a great privilege and an honor to be here in Riyadh at this meeting. So I'm not sure if the topic was put in purpose at this time at the end of the day, so the nutritional evaluation and management in cirrhotic patients toward the end of the day after lunch. So I think my main goal to keep you awake rather than reaching this objective by the end of the talk. However, I would like to go over some epidemiology about malnutrition in cirrhotic patients, and then I will elaborate on some terminology that we used and definitions, and then go through the pathophysiology and the impact in quality of life, and finally discuss some of the risk assessment scores that has been described in the literatures and our local experience in rehabilitations of liver transplant candidate. So, before we go into the definition, we all know that any insult or any chronic insult for the liver that precipitate a cascade of inflammations that goes on, and that lead to early fibrosis, which progress to cirrhosis. And then once you have cirrhosis, that's when you start to have complication either related to portal hypertension or liver cell failure. And we know cirrhosis, prognosis from cirrhosis is mainly related to the degree of decompensation. We know the risk of malnutrition in compensated cirrhotic is around 20%, and it's around 80% on decompensated cirrhosis. So it's a fairly common problem, and especially in the pre-transplant populations or the patients with child C that required liver transplantation. So how do we define malnutrition? When we look at the definitions, the biggest four society that has defined malnutrition is the American Society of Parenteral and Enteral Nutrition, and also the European Society of Enteral and Parenteral Nutrition, American College of Gastroenterology, and the International Society of Hepatic Encephalopathy and Nutrition. So they define malnutrition based on anything over or underweight. So undernutrition, which is underweight, and also it involves, this umbrella of malnutrition involves overnutrition as well. So when we translate this to numbers, underweight is any body mass index less than 18.5, and any overweight that defined by body mass index above 25. My main focus today will be on focusing in patients underweight, and we'll leave the other groups at a later time. So, when we look at the definitions by the European Society of Parenteral and Enteral Nutrition of malnutrition or underweight, it includes multiple variables, including weight loss, muscle loss, and also body mass index and fluid intake. And also the International Society of Hepatic Encephalopathy share most of the variables in the definitions. Some of the other definitions or other terminology that always expressed when the undernutrition or malnutrition comes around is frailty. Frailty is a progressive age-related decline in a physiological result, and that's involved physiological functions, cognitive functions, and that lead to disability. Another terminology is sarcopenia. It's all becoming very popular, and it's a progressive loss of muscle, skeletal muscle strength and mass. And the most widely assessment measures is through imaging, such as ultrasound, CT scan, or MRI. CT scan has been studied in several studies and showed at the level of L3, measuring the psoas muscle diameter or volume, muscle volume, it's one of the mostly studied predictors. And we know, and I'll show you later on, how sarcopenia is associated with malnutrition and poor prognosis. So now let's switch gear to pathophysiology. We know with cirrhosis you have a cascade of complications that happens. So the pathophysiology of malnutrition or undernutrition in a cirrhotic population is related to several factors. The most important two factors is decreased energy intake, and that's most likely related to ascites, anorexia, change in taste, and also increase in energy demand or energy needs by the hypermetabolic state. Other endocrine dysfunctions and malabsorption related to complications related to cirrhosis also participate in the pathophysiology. So this is how to summarize this. When you develop decompensated cirrhosis that lead to malnutrition, and that put you at risk for hepatic encephalopathy and bacterial infections, and that definitely impact your survival and increase the death on the wait list for liver transplantations, and also increase the risk of post-operative liver complications. So we know that the most widely predictor for prognostic factors or independent predictors for survival in patients with decompensated cirrhosis is MELD score and Child-Pugh classification. However, I'll try to convince you that malnutrition affects survival in cirrhosis regardless of the underlying Child-Pugh classifications and MELD score. This is a study done, multi-center study, was based in Italy, done in 1996, and it looked at malnutrition mainly by mid-arm circumference and mid-arm fat circumference, and looked at underweight and compared it to normal weight based on body mass index. And there was a statistically significant reduced survival in patients who moderately to severely underweight. And then when they sub-analyzed the group based on their Child-Pugh, if you look at the left side of the graph on the left side, it showed that if you below the 5th percentile in terms of child and above 5th percentile with a Child A classification, that definitely has a statistically significant p-value with higher mortality. Similar to Child B, Child C, where there is no statistical difference between the two groups. Another study that looked at the malnutrition specifically in patients with compensated cirrhosis, and it definitely showed similar result with a statistically significant p-value in patients with mild to moderate malnutrition compared to well-nourished patients. Finally, muscle wasting also been associated with mortality. This study was done by Aldo and his group in Edmonton, Canada, and it looked at sarcopenia-related mortality regardless of Child-Pugh and MELD score. And they found a higher mortality in patients who has sarcopenia compared to non-sarcopenic patients. So definitely there is increased risk of death on patients with cirrhosis, even if they are compensated or Child A with or normal MELD. So how do we pick up these patients in the busy outpatient clinic? We'll go back to the nutritional risk assessment that has been identified by all of these previous society I mentioned to you. And the best one that has been found to be the best predictor is the Royal Free Hospital Nutritional Prioritization Tool. And it's a very good independent predictor. other tool has been validated and has been studied. However, it was not validated as the Royal Free Hospital Nutritional Prioritization Tool. And to simplify, it's a very simple tool, can be done by a clinician in the clinic. And the step one question, or the first question, is, does the patient has evidence of acute hepatitis or has been in tube feeding? And if the answer is yes, then that takes you straight to severe malnourished, high risk or severely malnourished patient. If the answer is no, then you assess the fluid status of the patients, and based on that, either they have increased fluid volume overloaded or not, and then you go through the question. The only thing you need to know, if you find any risk factor, so you only need one risk factor to identify high-risk patients. Once you identify that patient, then your job is done. You need to get an expert to help you or to guide you to move forward. So the most likely that the first step to take this patients to further evaluation by a dietitian. There are several dietary recall has been looked at as a best predictor of daily calorie intake, and 3 days recall found to be the easier and the most reliable tool by the dietitian. And you need to dig more. And this is basically, it's impossible for a physician to do this. So that's why the dietitian has a very vital role in assessing these patients. Second step is to assess the body composition and assessment. This is when it gets dicey. This slide is very busy. However, let me take you through the two big categories in this slide. So the first step, or the first group of tests that you can do, is the anthropometric measures, which depend on body mass index and also bioelectrical impedance analysis. These two modalities very easy to do in an outpatient setting. However, it's very variable and it has impact. It can be impacted by fluid status. The second group is imaging, and that's ultrasound, CT, or MRI. As I mentioned to you, CT scan has been studied, and it's a very good test modality. However, all the imaging modality lack of the cutoff points or the normal reference range. So I would suggest to use the available imaging or anthropometric measures to assess the body composition in terms of muscle mass, and then combine it with the other tools to help guide you how to rehab these patients. The next step is functional assessment. This is also very simple and can be done in a clinic. Hand grip test is very widely available to assess the functions of the muscles. Also, 6-minute walks is one of the most widely accessible and easy to do tests. And then the frailty scale. Frailty is coming from frail, fatigue, resistance, ambulation, illness, and loss of weight. Finally, you need to sum all that together in a global assessment. And global assessment, it has two parts, the medical history and the physical examination. Medical history, it has several factors, including weight, dietary intake, GI symptoms, and functional impairment. Then you move to the physical examination part, which has the muscle wasting assessment, subcutaneous fat, and also presence or absence of edema. So, in summary, once you identify these high-risk patients or malnourished patients, you need to do an comprehensive assessment, including the dietitian's imaging modality, and then global functional assessment. Once you do that, then the question is, what do we do next? So now I'll switch gear to our protocol or our local practice at London Health Science Center. A few years ago, the main way of assessing these patients or picking up is just you need a doctor that eyeball the patients and then discover he seems to be frail or he seems to be malnourished, and then that will start the cascade of consulting the dietitians and the physiotherapist. However, over the last 2 years, we developed a new program to assess and pick up these patients that come for liver transplant assessment. The first test is time to go up and time to get up and go, and our target is less than 20 seconds. If the patient take more than 20 seconds and score very low on the hand grip test, then they get an extensive assessment by dietitians and physiotherapists. We also do ultrasound to assess the rectus femoris muscle thickness, and we do also MOCA examination, and this is mainly for research and future use purposes. Then they see the dietitian, and they get a full assessment by a physiotherapist for 6-minute walk. The dietitian tries to optimize their dietary intake, and the physiotherapist try to see if they can reach the minimum of 6-minute walk, which is 250 meters. If they failed either of these two tests, then we start the rehabilitation program. Step number 1, we start as an outpatient with oral supplements. So the dietitian recommend for them any kind of supplemental drinks. They have to drink 3 to 5 per day on top of what they can eat. Physiotherapists advise them to have a local or home exercise program, and the main goal from that program to prevent any further loss of muscle mass and to improve efficiency of the muscle actions. Then they come back 4 weeks later. 4 weeks, this is how they start, and this is what you are expecting them to be. However, this is the reality. They come worse than they started at the beginning. Then, if they are deemed a candidate for liver transplantation and the only obstacles is their nutritional status or physical limitations or frailty, then we offer them an inpatient rehabilitation program. So they get admitted, started in tube feed and by the dietitian, and start slowly and escalated according to their tolerance. And they start our rehabilitation program. This is our rehab unit, and this is our physiotherapist who presented our program at ASLD in Washington last year.
2 minutes.
And then they get reassessed in 2 weeks after aggressive inpatient rehabilitations. So the hope by the end of 2 weeks to go from this up to this with improvement in their muscle mass, physical activity, so they can be activated on the list. Unfortunately, if they don't respond to inpatient rehabilitations with aggressive feeding and physiotherapy, then they can't make it to the transplant list. That would be, unfortunately, a limiting factor because their body failed and their cirrhosis is too advanced to be listed for liver transplantation. We do some offers. We offer them to continue in tube feed at home and physical rehabilitations and see if that will help. However, we have very bad luck in rehabbing these patients, fail inpatient rehabilitations. Sometimes we try. Sometimes we try TPN. However, that's also very restricted, and we didn't have a very good success. So, in conclusions, malnutrition, regardless of the definition, is an independent predictor for poor clinical outcome in cirrhosis. Adapting a minimal element of nutritional screening assessments, it should be done in all tertiary and secondary care centers, and establishing a rehabilitation program for high-risk patients to improve liver transplant outcome and overall survival. Thank you.
Thank you very much, Dr. Karim, for being very thorough and concise to the time.
Would like to call all of the speakers to the podium, please. Professor Sam Lee, Dr. Ahmed Al-Eid, Dr. Kamasani. We have questions on the application, but we'll take questions from the audience first. Please go ahead if you have questions.
Actually, thank you for everybody who presented in this session. Particular thank for Dr. Sam. He thought that his speech will be something like boring or not understandable. I'm really excited because I gathered from before, in our culture, we have something we call al-dhaka, that when you slaughter the animal, it should be slaughtered first the blood vessels, keep it for a while until the animal is like struggling and the heart will be pumping, keeps pumping with that mechanism that you mentioned. The connection between the brain and the heart persists until the heart empties all the blood out of the animal's body. And then when the animal is already ceased, then to continue and cut the nerve. This process is from the ancient ages, and it's in Quran, and I think in Torah. I'm not sure about the Jew, if they have this method to get rid of all the blood which has the toxic products in it. It's not my intelligence that made me, that have this connection. Actually, I think I heard it from Dr. Zaghloul al-Najjar. He's one of the Arab scientists. He's an Egyptian, or maybe Dr. al-Nabulsi. But I'm thankful to hear it in this conference with all the educated people around. Maybe we spread it in the world. This is a scientific thing.
Thank you. Any comments?
Thank you very much.
You want to comment? Or no, nothing? Okay, thank you. Any more questions from the audience before we take questions from the application? Please, Doctor, go ahead. Okay, the first question is to Dr. Ahmed Al-Eid. There is a question about, is it mandatory to do gastroscopy before starting anticoagulant to rule out speech varices, I guess, right? What do you think, Dr. Ahmed? You press the button.
Yeah, I think it's standard of care to perform endoscopy for any cirrhotic patients, regardless whether he needs anticoagulation or not. But yes, it's recommended to do endoscopy before initiating anticoagulation to adapt primary esophageal variceal bleeding. Primary prophylaxis for esophageal varices, sorry.
Okay, thank you. Another question to you, Ahmed Al-Eid. I think there is an audience are concentrating on your talks. What is the indication of anticoagulation for tumor thrombus, even in patient who is a candidate for liver transplantation?
Yeah, usually tumor thrombus is an exclusion criteria for liver transplantation based on Milan criteria. The presence of tumor thrombus indicating advanced disease, very short term survival. There is no clear indication for anticoagulation in patients with a tumor thrombus.
Thank you. A question to Professor Sam Lee. How can we use the data from animal models in our clinical practice? Any drug in the pipeline that can utilize this?
Thanks for that question. I don't think the field is ready yet for application of those animal observations to routine clinical practice, and certainly I'm not aware of drugs that we can use at the moment to block nNOS. nNOS has too many other widespread effects. If we block that, there would be deleterious effects in other parts of the body.
Maybe the pharmaceutical companies are busy with the antiviral therapy more than anything else in this mind. It's more money, more, yeah.
That's probably correct, but soon we'll have no hepatitis C anymore, so
and they will back to it.
So we have to find other diseases.
Okay, Dr. Hamad Shujaa has a question, please.
Dr. Gomosani, thank you for sarcopenia. Is really an interesting subject. If you have a patient listed for liver transplant, and you do and you check for sarcopenia, your program is it successful? If there is a cut that you will not do a liver transplant, do you delist the patient if he's sarcopenic? What are your guidelines regarding sarcopenia? Is it reversible, and how much you can improve it? many questions.
Thank you, Dr. Hamad, for the question. So sarcopenia is not yet as part of the criteria for listing for us. We use the 6-minute walk and also the hand grips, and that's the two main physical tests that we do. Sarcopenia, we do check for sarcopenia. We encourage them we try to improve their dietary intake. However, we never delisted any patients who is sarcopenic from our transplant list. But we have delisted patients that who is failed to do a 6-minute walk before and after inpatient rehabilitation program.
Is it reversible with your intensive?
Well, it's reversible once they have transplant, but before the transplant, I'm not too sure.
Thank you. I have a question here for Dr. Samli as well. Since the changes after portal hypertension start centrally, do you expect we will be able to find biomarker to predict future complications?
Yes, that's certainly one of the areas that's actively being studied. We're especially interested in looking at biomarkers for cirrhotic cardiomyopathy in particular, pre and post liver transplantation, and in other situations. So yes, I think biomarkers are an active field that we'll see a lot of progress in the next 2 to 5 years.
Thank you. Any more questions from the audience? If not, we want to close the... Hamad, once again.
So this question again for portal vein thrombosis. So if it is extensive portal vein thrombosis, is that absolute contraindication for liver transplant, or do you go for possibility of clearance? Type 4 and type 5, do you clear the portal vein thrombosis? Is that absolute contraindication, extensive portal vein thrombosis?
So, well, for grade 1 and 2, they are not contraindication, not considered to be contraindication for liver transplantation. But for grade 4, in some transplant center, they consider it as absolute contraindication for liver transplantation. For grade 3, they can do jump graft or alternative vascular reconstruction. But however, in some patients going for liver transplantation, they are they are discovered only during liver transplantation. So some of the transplant surgeon will be faced by challenge during liver transplantation before knowing that at the time of surgery. Karim?
So yeah, so I agree with Ahmed. The only thing is if they have to have something to connect to the portal vein. So if they have patent SMV or patent splenic vein, then they will try to do the transplant, but it's very challenging, and sometimes they have to do IVC conduits and to reconstruct if they're completely thrombosed.
I have a question about portal vein thrombosis. Let's say you have a patient on long-term anticoagulation and their portal vein thrombosis is not changing, it's not recanalizing, but it's not extending. How long do you keep that patient on anticoagulation?
Yeah, for those patients who are listed for liver transplantation, the general recommendation to keep them on anticoagulation till the time of liver transplantation. Yeah, there is no good evidence to say that patient who is not a candidate for liver transplantation, if you anticoagulate those patients, there is no much benefit on the survival. As a general recommendation, it's not recommended to anticoagulate those patients who are not listed for liver transplantation. However, you need to individualize your patient if he develops any symptom or sign of bowel ischemia. Then at this point, you may consider it.
Thank you. I'd like just to announce, Dr. Hamdan, you have a question? Hamdan.
This is a question for Dr. Karim. I wanted you to highlight on the importance of or the relationship of sarcopenia with hepatic encephalopathy, and how big is the evidence if you improve the nutritional status and sarcopenia that the ammonia could be cleared by the muscle. Second thing, how big is the evidence that if you build up the nutrition of cirrhotic patient, that his survival will improve as compared to his transplant outcome if you build up his nutrition?
Well, for the first question is the sarcopenia and hepatic encephalopathy. So most of the studies that looked at sarcopenia, there is a correlation between sarcopenia as a part of a marker for malnutrition. However, it was one of the, in some studies it showed it was one risk factor for hepatic encephalopathy. So, but I'm not too sure if there is a true correlation between the two, but it's definitely increased the risk of decompensations and hepatic encephalopathy. With regard to the second question, the improvement in sarcopenia related to mortality. So I don't know if we got to the point that we can improve sarcopenia before transplantation. However, we know from all the data that the best outcome or the best predictor for outcome after transplantation is the nutritional and the physical status of the patients at the time of the transplant. And as well nourished and as physically fit at the time of the transplant, as low as the post-operative complication, hospitalizations, and better prognosis in terms of patients and graft survival.
Thank you. Just one announcement before we close the session. Tomorrow morning, 7:30, there will be Meet the Expert session on IBD. We'd like to welcome you all to attend this session, very important session, 7:30 tomorrow.
Well, we'll conclude at the end of the session. Please accept our gratitude. Thank you very much for your participation and very nice presentations. And more importantly, that you have stuck to the time, all of you. Thank you very much, and thanks for the audience to stay that late. Thank you.